Creamer Media's Policy, I'm Sashni Whitley. Joining me today is Discovery Health CEO Jonathan Bloomberg, here to discuss the NHI bill and the Medical Schemes bill. Now, you recently published some of your views on the National Health Insurance Bill and the Medical Schemes Amendment Bill, which the Department of Health issued for public comment recently. Has Discovery Health made formal submissions on these pieces of legislation, and how do you see the process unfolding?
So, we have certainly made formal submissions on both bills, the National Health Insurance Bill and the Medical Schemes Amendment Bill. As far as we understand the process, what happens now is the Department of Health needs to take on board all of the various submissions that have come from stakeholders, study them, make changes as they see fit based on those comments, and that the bill then gets amended and goes back into the parliamentary process. It goes to the Portfolio Committee for review and then finally to Parliament for a vote. We're not sure of the timing, but as we understand it, it's likely to be after the elections, probably sometime next year.
Access to health services in South Africa continues to be highly unequal. Do you think that greater equality can be achieved in our health system?
My honest view is that the overwhelming priority is to improve the quality and accessibility of existing public health services. These are funded through taxes, which means that the majority of people who need them can access them free of any user charges. And if those services were of high quality, in your local community for primary care and in your local hospital for hospital care, then I think you already would be significantly addressing the issues of equity and equality in the health system. So that's very much the first step.
Now, initially, the NHI tends to focus on critical services for vulnerable groups such as school children, the elderly, mental health patients, and cancer patients. How do you think this policy will work in practice?
I think that first phase is fairly clear. The government, the Department of Health has identified those vulnerable patient groups, and it's actually done more than that. It's identified where those patients are, in which communities, and in some cases actually has clear lists of who those patients are. And the Department of Health has put out a tender asking entities like medical scheme administrators, but also others, to come forward to bid for a tender to take that money and procure services by contracting with private providers, specialists, hospitals and others, to deliver those services. So we Discovery Health has submitted a bid for some of those tenders, as I'm sure many others have done. And so I think fairly straightforward implementation there. Those tenders get awarded, the successful bidders go out, sign contracts, for example, let's say with oncology practices in KwaZulu-Natal to deliver those services to the patients that are identified by the Department of Health.
You indicate that under the NHI there will be free treatments for those who follow the NHI's referral pathways, but that those with medical aids will retain the freedom to choose which doctors and hospitals they wish to use. So do you think that it will make sense for companies to continue to subsidize the employees' medical aid benefits?
There's a lot of confusion around over what kind of time frame NHI properly manifests. So we do have a timetable from the government, but I don't think anybody can confidently say in 2026 or whichever year you choose, there will be an NHI and it will cover all of the following services. So that's the first very important point. The second ambiguity is that even when, for example, the example I often like to give, let's take maternity services for a pregnant woman who needs antenatal care and delivery and postnatal care. Let's pick a year, let's say it's 2025, and the NHI is offering those services. But it says to you, if you live in Sandton, you need to go to the local clinic for your antenatal care and to these two hospitals or clinics, let's say Alexandra Clinic and Helen Joseph, for your delivery. Now let's say you don't want to do that. What's clear is that you can't claim from the NHI because you've gone privately now. What's not clear is, can you still claim from your medical aid? That is ambiguous, and I think it's really quite important that that ambiguity be clarified over this period of comments and the clarifications of the bills. We have a very strong view, which is that all citizens must contribute to NHI, but once they've done that, they must also be free to have medical aid if they want it, and to be able to claim from the medical aid for whatever services they purchase, and that there shouldn't be a restriction on that. I think in that world, I want to properly answer your question, I think employers will almost certainly continue to subsidize. Many employers don't make medical aid compulsory, so they will say, you can have medical aid, we will give you a subsidy. If you prefer not to, then you don't join. And I do think it's possible in 5, 10, 15 years, as the NHI gets better, that say low-income employees will say, you know what, we'd rather just use the NHI, and they won't then need a subsidy from the employer. But I think many others will prefer still to have medical aid. If you take the example of the United Kingdom today, it has the NHS, which is a brilliant health service. It's free, but still 11% of the British population, that's over 6 million people, choose to have private medical insurance because they either want to get quicker access or to choose their specialist or to go to a private hospital. And we believe that people should retain that right in this country as well.
How do you think the state will fund treatment for those who use NHI?
So, today you have a public sector budget for health, and the Minister Mboweni, updated those numbers yesterday, and they're heading towards 250 billion rand of public money for the public health system. And that comes through tax revenue. So all of us pay income tax, VAT, various other kinds of taxes, and those tax monies fund the public health system. To me, that is the backbone of the NHI money as well. In other words, that money is the starter money. The question then becomes, how do you raise additional money? And there's many debates about that. Some people talk about possibly a new payroll tax or various other kinds of taxes. I think it is almost certainly accepted by virtually everybody now that in its present state, our economy can't sustain additional tax increases. So I think for the next several years, there's no possibility of new taxes for the NHI, and it'll have to be built using the existing public sector budget.
The Minister of Health has said that under the NHI, the rich will subsidize the poor. Does this fall under the tax scheme? Yes,
that's how I interpret what he's saying. I mean, already we do have a very progressive taxation system, so it's quite steeply progressive. As you earn more, you pay significantly higher rates of tax, and in that sense already in this country the rich are subsidizing the poor, not only in health services but in education, in security, in all public services. So I think that is already the case, and if there is an additional tax at some future point, it will probably be progressive as well. In other words, higher income employees will pay more. So if it's, let's say, 1% of your income as a payroll tax, it'll be progressive again. So I think that's what he means.
Now, turning to the Medical Schemes Amendment Bill, there have been some reports that all co-payments will be abolished under this new law. Is that in fact the case?
I think when you go and read the draft legislation, that's not true. The legislation says that there will be a set of compulsory benefits in the medical scheme. Today you have so-called prescribed minimum benefits, or PMBs. Those will get a new name. They'll become a sort of comprehensive service benefit package. There'll be a new definition when that is done. But what the legislation says is that for those services, a medical aid must ensure that members are covered in full with no co-payment. So the medical aid must go and do contracts with hospitals and doctors and others to make sure that for the comprehensive service package, for those benefits, there is no copay. Now, if a service is not in the comprehensive package, then there may still be copays. And that's pretty much what we have today. With PMBs, there can be no copays. But you can have a copay if you have a non-PMB treatment, or if you elect to go outside your medical aids networks for your PMB. And it's the same in the new Act.
Will there continue to be a role for medical aid consultants under the new law, and what will their role be?
Certainly. I mean, I think that, in our view, as I was giving the example earlier of Britain, I could also talk about Australia, which has a national insurance system, but 30% plus of the population have private health insurance, and there are dozens of examples like that. So in countries with fully developed NHI, you still have private health insurance. We will still have private health insurance. And the question then becomes, do ordinary consumers need good advice? And the answer is yes, because health insurance is a complicated product. And you do need independent brokers and consultants to study the market, ask the consumer, what are your needs, what's your affordability, and match the consumer with the best product.
Finally, the Minister of Health has indicated that the Council for Medical Schemes should develop new capital requirements regime for medical aids. What are the reasons for this proposed change, and would such a change be likely to impact positively or negatively on a company like Discovery Health?
Right, so it's an important question. So currently the law states that a medical scheme has to keep a reserve fund equal to 25% of the premiums. And the problem with that very blunt number is that it leads to certain medical aids keeping excessive amounts of reserves. And that is members' money, okay, remember that. And it leads to some smaller schemes keeping too low a level of reserves, because for a small scheme, where the risk can change very quickly, in a small scheme you can have a few huge claims that can literally bankrupt the scheme. 25% may be too little a reserve for a small scheme. So all around the world, governments have moved to a different kind of approach to regulating the reserves of insurers, and that's health and other kinds of insurance. They take what's called a risk-based approach. So you have a formula that says, let's understand the true risk faced by this medical aid. That's a function of its size. So a very big medical aid like Discovery Health Medical Scheme has got very low risk because it's very, very big. But you also look at other things. What is its demographic profile? How well is it managed? Etc., etc. And that would lead you to a formula that says a scheme like Discovery should have only 8% of premium in reserves, for example, or 10%. And we do think that the Discovery Health Medical Scheme, which currently has reserves close to 18 billion rand, by the way, probably needs less than half of that. And if that change came, for many schemes, they would be able to hopefully keep their premium increases significantly lower every year, and even give enhanced benefits as they seek to return some of that excess capital back to members. Of course, there's some smaller schemes that would need to build up more reserves, but that's also important because the members of those small schemes are under-protected at the 25% level. So in summary, we think this is a very overdue move, and the sooner that it is introduced, the better.
That was Discovery Health CEO Jonathan Bloomberg joining us today to discuss the NHI bill and the medical schemes bill.